So now we will go to drugs, very simple drugs, which are called adrenergic drugs. Adrenergic drugs, also called as sympathomimetics. Sympathomimetics. They are of three different types. First ones are called direct acting. If there is something direct acting, there has to be something called as indirect acting, and third one is mixed acting. So three types of adrenergic drugs: direct acting, indirect, and mixed acting. Direct acting always means a drug that will cause direct receptor stimulation. So drug will go and directly stimulate the alpha or beta receptor. Direct receptor action is there. Drug itself will go and bind to alpha or beta receptor. Direct acting drug. So you have a drug, you give the drug, it goes and binds to alpha, beta or both and causes their stimulation. Direct action. Directly acting drugs are further classified into two types. They can be drugs which can be called as catecholamines or non-catecholamines. So these are two types of directly acting drugs: catecholamines and non-catecholamines. Catecholamine, non-catecholamine. These are types of directly acting drugs. You just need to understand that in your GIT, there is an enzyme, very simple diagram I am showing, called COMT. In our intestine, there is an enzyme called catechol orthomethyl transferase. C catechol, O for ortho, M for methyl, T for transferase. This enzyme will break any catecholamine. COMT will metabolize which drugs? Catecholamines. So that means catecholamines cannot be given by which route? Oral route. So they are not orally active, while non-catecholamines can be. And catecholamines cannot cross blood-brain barrier, while non-catecholamines can. So these are the 2 points. Catecholamines cannot be given by oral route. They all will be parenteral. We will have to bypass GIT and they will not enter CNS. They cannot cross blood-brain barrier. Catecholamines are further of 2 types. One which are present in our body called endogenous catecholamines, and those which are not present in our body called exogenous catecholamines. These are 2 types of catecholamines. Endogenous, there are 3 molecules. Number 1, adrenaline. Number 2, noradrenaline. And number 3, dopamine. These are 3 endogenous catecholamines and their names are commonly asked. Adrenaline, noradrenaline, dopamine. Exogenous are all synthetic. So 3 important ones we will discuss: do-butamine, phenyl, dopam, and third is isopranylene. These 3 we will discuss. So we have started discussing the drugs. Drugs are adrenergic or sympathomimetic drugs. You should be very clear in any chapter about the classification of drugs. So drugs are classified into 3 types in this system: direct acting, indirect and mixed acting. Direct acting focus on direct. Direct means drug will go and act on the receptor itself. They are of two types, catecholamines, non-catecholamines. Why should a doctor know which drug is catecholamine? Because catecholamines cannot be given by which route? Oral. There are 6 catecholamines important in total. 3 are endogenous, 3 are exogenous. We'll discuss all of them one by one, starting with dopamine. Very, very important substance. The first drug that we will discuss, dopamine. Dopamine will have what we call as dose dependent actions. Action will depend on the dose. Dose dependent action. So you remember this dose, 2 to 10 microgram per kg per minute. This dose you have to remember. 2 to 10 microgram per kg per minute. Now, one dose can be less than this, so less than 2 microgram per kg per minute. And the third dose can be greater than 10 microgram per kg per minute. So low dose, moderate dose, high dose. Less than 2, low dose. Then you have 2 to 10, moderate dose, and greater than 10, high dose. Dose dependent action. Action will change according to the dose. At low dose, less than 2 microgram per kg, it acts on D1 receptor. Positive signs means stimulation. So at low dose, it acts on which receptor? Dopamine type 1, D1 receptors, which are present on mainly renal blood vessels. And these receptors cause vasodilation. So they are vasodilatory receptor. So at low dose, less than 2 microgram per kg per minute, it will act mainly in kidney and cause vasodilation. So what will increase? Renal blood flow will increase. The renal vessels will dilate, more blood will come into kidney, and that will increase urine output. So urine output will increase. So in low dose, very low dose, it will act in kidney, increase urine. This only low dose is never used. Okay, this is just for understanding. Now you increase the dose to 2 to 10. At this dose, it will continue to act on which receptor? Which action will continue? D1 stimulation will continue. So D1 stimulation leads to increase in urine, that we have discussed. That action will continue, it will remain. But at high dose, one action will be added. When you increase the dose above 2, it starts also acting on beta 1 receptor. It also starts acting on beta 1. Now beta 1 action is added, dose dependent action. Beta 1 is present where? Heart, and beta 1 is heart stimulatory. So that will increase what? Cardiac output. So now you look at this drug, actions of this drug. At the same dose, 2 to 10 microgram, it is increasing cardiac output and also urine. So when urine is more, fluid accumulation in body will decrease. So congestion in body will decrease. Congestion is what? Accumulation of fluid. You have more urine, so congestion will decrease. It is increasing cardiac output. So which failure will be improved? So where do you think will be this dose will be used? What will be the use of dopamine in this dose? In which disease? Congestive heart failure. It will decrease congestion, improve heart failure. Urine output and cardiac output both will increase. Congestion will go down, heart failure will improve. Understood? What will be the route of this drug? Oral or IV? Now simple thing I'll ask you, gradually it will become clear. IV drug, that too per minute infusion. IV is also of two types. You fill the syringe, inject it, that is called IV bolus. And another is you set up a drip, IV infusion. So per minute dosing can be done by bolus or infusion. IV route, that too infusion, will be given in OPD or admitted patient. Clear? Who is admitted? The patient who has mild symptom, mild disease or very severe disease. So that severe CHF you call as acute decompensated heart failure. In medicine you will discuss the nitty-gritties, but broadly I am telling you, there is a patient of heart failure, he has mild symptom. He will be treated in OPD or IPD. OPD, which route is used? Oral. Someday he develops worsening of symptom due to XYZ reason. He will now be admitted and given which drug? IV. So this is a drug used in CHF, but which kind of CHF? Severe CHF, or you can call acute decompensated CHF. When we go to CHF chapter, we'll come back to it. Understood? So first use of dopamine is in treatment of heart failure. High dose, further high dose, which action will continue? D1 action will continue. That is going to increase urine. Beta 1 action will continue. That is going to increase cardiac output. At this dose, one more action will be added, and that is alpha 1 stimulation. Now alpha 1, you all know what it causes. What is the main role of alpha 1 in our body? What was the mnemonic of alpha 1? Probe. The main role I told you is vasoconstriction. And when vessels constrict, BP, so alpha 1 increases BP. You combine all of them, what is the use that is coming out? Why do you want to increase BP of any subject, any patient? For treatment of what? Shock. So for treatment of shock, try to understand, we want to increase BP. BP can be increased by causing vasoconstriction. You constrict the vessels, BP will go up. So we have several alpha 1 agonists available in market. What is the use of dopamine? Right, there are several drugs available in market which act only on alpha 1. You can use them, you can constrict vessels, BP will go up. Why to unnecessarily stimulate beta 1 or D1? So we come across situations which, if you have been to ICU or CCU, you will find it's very common. The patient has low BP. Because BP is low, blood going into kidney is also low. So patient has shock with oligouria. Most of the cases of shock will also have oligouria. Most cases, not all, but most. So what do you want to do? You want to increase blood pressure, but you also want to increase urine output. So you need a drug that at the same time can increase blood pressure throughout the body. It causes vasoconstriction, BP goes up, but in kidney, it causes slightly so urine output goes up. And there is only one drug in pharmacology that can do both of these things, that is dopamine. Given in which dose? High dose. So if you are asked what is the pressor dose, pressor means vasopressor. So if you are asked what is the vasopressor, or simply you are asked pressor dose, then you are looking for which dose? High dose. If you are asked cardiac dose, you are looking for moderate dose, and if you are simply asked renal dose, then you are looking for low dose. These are the three dose dependent action and two uses of dopamine. Understood? Dopamine has two uses which are written in front of you. Congestive heart failure, which I told you which kind of heart failure? The severe one. And shock. Again, patient is severe. So it is a drug of emergency mostly. Emergency or ICU. Complicated. Route is what? Look at the dosing. IV infusion. So you go to ICU. Most of the patient in ICU, most patients are not able to maintain their BP. You will find dopamine dosing goes on. If only cardiac action, moderate dose, high pressure action, high dose. Understood? Which disease has deficiency of dopamine? But dopamine cannot cross because it is a catechol, and that is why Parkinson cannot be treated with dopamine. Understood? The point that we have written above, that catecholamines cannot cross blood-brain barrier. So dopamine cannot be used for treatment of Parkinson simply because it is a catecholamine. If the drug was not a catecholamine, it would have made Parkinson treatment very simple. So it cannot be used for Parkinson. This is about dopamine dose-dependent action. Okay, questions are generally asked on pressure. You need to understand these catecholamines are drugs for the life-saving drug. So if you have not been, go to ICU, you will find their use so frequent that, emergency medicine also I think is taught nowadays, separate section. In emergency medicine, this life-saving ALBS, BLS, all these courses, these are the kind of drugs that we'll discuss. Next drug is dobutamine. Dobutamine. Dopamine is over, dobutamine is the next. Dobutamine, it's a pure beta 1 agonist. Beta 1. Present where? Where is beta 1 present? So it's a cardiac stimulant. It increases force of contraction, FC. Force of contraction much more than heart rate. So it is basically an inotropic drug. It acts on heart. In heart there is contraction, conduction, two things are there, separate things. It mainly acts on contractility. So contraction of heart will increase. So when heart will contract with more force, what will increase? Cardiac output. What can be the use? Again, heart failure. Which kind of, again, what is the dosing? Same almost. Now you will just change the name. You will call it cardiogenic shock. Now you just need to understand, this is more of medicine, less of pharmacology. Patient has gone into shock. What is shock? Shock is hypoperfusion of vital organ. Why patient has gone into shock? Because of cardiogenic reason. Heart is not contracting enough. That is why cardiac output is low. That is why patient has gone into shock. If you stimulate the heart and if it contracts more, blood will come into aorta and shock will go away. So cardiogenic shock can be due to CHF, it can be due to post-MI, it can be due to any goddamn reason which affects heart. So anywhere you have cardiogenic shock, what is the drug of choice? Dobutamine. So sometimes the word cardiogenic shock is written in the use, sometimes CHF is written in the use, sometimes post-MI is written in the use. All you need to understand that due to any problem with the heart is not contracting sufficiently. That is why there is shock. So we want to stimulate heart. Which receptor is present on heart? So we want a drug that acts only in heart. Does this patient has any problem with blood vessel? So we don't want to unnecessarily affect blood vessel. So which is the drug of choice for cardiogenic shock? Dobutamine. What is the dose? Same 2 to 10 around. Second, it can be used for diagnosis, not treatment, diagnosis of ischemic heart disease like angina. Ischemic heart disease, you all know, coronary heart disease or ischemic heart disease. What is that called? That is called dobutamine stress echo. A test is performed. What is done in this test? We give IV dobutamine, high dose, 20 to 40 microgram per kg per minute. high dose of dobutamine is given. IV. It acts on beta 1. So force of contraction increases. That means cardiac work increases. That means oxygen demand of heart will increase. And after giving this, you perform the echocardiography. And you can, if patient has anginal changes, they can be seen on echocardiography. If patient has coronary artery disease. So coming to coronary artery disease, some basic things I'll tell you. What is the symptom in coronary artery disease? What is the complaint? Chest pain. Patient comes to you, you are the cardiologist. Patient comes to you, say, Doctor Sahab, I had a very serious, severe chest pain 2 hours earlier. I felt as if my heart was being crushed, as if an elephant was sitting on my chest, as if the world was coming to an end. Such serious heart pain, chest pain I had. At this moment, then I was, doing jogging or running or stairs I was doing. I had such severe heart pain. I to completely lied down. Completely. I thought I'm gone. Then when I relaxed, lied down, rested, gradually my chest pain improved. I am very worried. Now I have come to you. Now at this moment, do you have chest pain? No. What is the commonest cause of retrosternal or chest pain? The common cause? Gastritis. Out of 190% cases of chest pain are due to gastritis. What is the first investigation you do when patient comes or complains of very severe chest pain? ECG. What will ECG show? ECG can show ST segment depression. Depression is a sign, ST segment depression is a sign of ischemia. But at the time of ECG, does patient have ischemia? So ECG can be normal. Or ECG can show ST segment elevation. Elevation is a sign of necrosis myocardial infarction. We are talking of a case of angina, where there is no infarction, only ischemia. At the time of ECG, when patient is in your cabin, he is not having chest pain, there is no ischemia, ECG comes out normal. Nothing is seen in ECG. So, what do you do then? Does it rule out angina? He has angina, but at the time of ECG, there is no ischemia. ECG is a pretty useless investigation in angina. What do you do then? How do you diagnose angina? Biomarkers. Biomarkers tell if broken necrosis, then proteins of the cardiac cell will come into the blood. But in angina, if you remember from pathology or medicine, in angina there is only ischemia, there is no necrosis. So there is no biomarker of angina, there are biomarkers of MI. So after ECG, what do you do next? What is the next investigation in chest pain? There are many, one of them is stress testing, treadmill testing. Patient is walking on treadmill, during that time you are taking ECG. Exercise means increased physical activity, oxygen demand goes up, you can see anginal changes. But what if treadmill facility is not available? Then you do stress testing by injecting which drug? Dobutamine. It's a stress test when treadmill is not available. So you inject dobutamine, it stimulates heart, beta 1, cardiac contraction, increases oxygen demand of the heart, goes up, and if the patient has angina, you can see them on echocardiography. So after giving IV dobutamine, you do the echocardiography that is used for diagnosis, as I have written, of angina. So dobutamine has two uses, one diagnostic and one therapeutic. Dobutamine T half is asked, one liner question, 2 minutes, and please remember it has no action on dopaminergic receptor. Name is similar to dopamine, but doesn't act on dopamine receptor. Dopamine D1 or D2 receptor, it has no action. It acts only on beta 1 receptor. It's a cardiac stimulant. T half is 2 minutes. Very short acting, given IV. Drug of choice in cardiogenic shock. Dobutamine stress test. Details will be discussed in medicine. Third drug, medicine, I don't think. When did your batch start? This coaching batch. So today we are in June, end of June. When has your batch started? June only. Most of you have joined. How many of you have joined in June? So how many subjects have you been taught since then? One or two? Which one subject everybody has been taught? Cardiology. So you do understand that what is going to change in next? Things will remain the same. All you have to understand, what we think will change is that there will be more clinical oriented question. Whether it will happen or not, we are not sure, but that is the actual guess. So what is this clinical oriented question? What is this? So clinical oriented is only how patient presents, what are the important differential diagnosis, which one is most common, how we rule out others, which investigation we perform, which is the first drug we give, which is the first line drug, which is the second line drug, which is the first investigation of choice. So ECG in chest pain is the first investigation. But you now know that most cases of chest pain are due to. So why are you doing ECG? 90% of the cases of chest pain will not have anything in ECG because they are acidity problem. So why you are doing ECG? Why you are doing ECG in 90 cases when you know it will not have anything to do with heart? Because you want to rule out the most serious problem first of all. If even 1% case have a MI, they will die. So ECG is done to rule out the most serious cause. 24-hour pH monitoring in stomach is not the first investigation of choice, although that will be useful in most cases. So once you understand things in a clinical fashion, that you are the doctor in emergency, patient comes, says, Doctor Sahab, I've got chest pain, very serious chest pain. What to do then? In Indian scenario, in practice, what we do? In practice in emergency, if you are there, especially in medical college, you will give this patient pantoprazole also, you will give him aspirin also, you will give him beta blocker also, you will do ECG also, you will do biomarker also, you can do anything in practice. But in theory, in MCQ, you have to go very step by step. So this knowledge that you are gaining is very step by step correct knowledge. Unfortunately, when you become the doctor, this is of zero use. Because patient wants immediate relief. By the time I reach home, disease should be gone. So you have a case of childhood diarrhea. Children diarrhea is common. What is taught? What you should give? Most of the diarrhea in children are which origin? Viral. So which drugs are useless? Antibiotics. What should be given? ORS and zinc. By 3 or 4 days, it will automatically resolve. But by that time in India, patient would have switched doctors. So you are the pediatrician, parent bring their child, lovely child to them, he is 1 year, 2 year having diarrhea, mother is obviously very concerned, and you tell them that take ORS, take zinc, nothing, no need, it will automatically resolve for 3 days. The moment They reach home, mother tears up the prescription. This doctor is useless. We are not going any time back to this doctor. I want a new doctor. My child is having diarrhea and he is saying it is of no concern. After 3 days, he'll improve. I want my child should get better by early morning. So then you go to a doctor who gives ORS, zinc, antibiotic, anti-ulcer, antiemetic, some steroid also, vitamin also, and some antioxidant or some zinc or something. Also tells the mother that you have taken very great care of the child. Look at the child, how well mannered or how well dressed he is. Mother says, this is the good doctor. So in practice, there are several different things. In most pediatric cases, you are not treating the children, you are basically establishing a rapport with the parents. If parents like you, child can suffer for what? So very educated, highly knowledgeable doctors think it is useless. I am just fooling the mother. He does not want to do this. He is highly knowledgeable. He knows everything crystal clear. He is focusing on the treatment. But he is unable to establish a rapport with the patient. In this case, mother is also a patient. So he does not say praises of the mother, that how well you have taken care of the child. While a less knowledgeable pediatrician knows little bit about the theory. His concepts are not very strong, but he knows how to handle the patient. So he says, child, you sit here. Let me establish a rapport with the parent or the father or the mother. Father, he says, oh, look at this. Oh, very good. What are you doing? Acha, you went to this school. I also went to this school or this. So that is why you will find the most knowledgeable doctors who are very good in theory, very knowledgeable. They develop a sense of ego, arrogance. And when they see an illiterate or a patient, I mean, all patients are illiterate in front of doctors. They have studied less than doctors. They have less knowledge, layman people. So they do not listen to their complaints properly. They know what is the treatment, but they are not able to satisfy the patient's complaint. Patients want to be heard. The doctor, I've got all these complaints. I have a joint pain, but my son does not spend any time with me, and he, my daughter-in-law is very against me or whatever. I have this complaint also, or my neighbor wakes me up, plays loud music at night, which wakes me up. This has got nothing to do with joint pain, but he just wants to be heard. So there are doctors who will put stethoscope on knee also. Patient think he has examined. Where are there other doctors, very senior, very good, very knowledgeable, who will just say, Patient से देखा ही नहीं डॉक्टर साहब ने, है ना? So you have to be a bit more sympathetic. Let him speak whatever he wants to speak. Let him tell his story. There are only few words of importance in his story, which a senior doctor, you are reading the story, he catches the main words. He has already written the prescription. So half of the time, by the time patient comes and sits, senior experienced doctor has written the prescription. If this patient requires this investigation. He is just listening to him. Establishing a rapport with the patient. And on the other hand, there are some doctors you will find in your colleges also, some professors are very knowledgeable. But the moment you go to them in their class, they first of all scold you. Why you have come? Why did you come? Why do you do this? Why this is wrong? Why this? Bhai, they are very angry. So you don't like going to them. They are knowledgeable, but their class is also good. But every time you go, they scold half of the class and create nuisance for you. So you don't like them. So same is the case with patient. So try to establish sympathy for the patient. That is very important. We teach 19 subject to our students. We don't teach them anything about sympathy. The patients are diseased. They want, half of the patients simply want to be heard. And in India, especially from poor background, remote places, they just want a IV infusion. The moment they come, old people from remote areas come, put them on the stretcher, start, even if you give saline, they'll feel better. For them, that is the treatment. Unless you give an injection, Maxab has not done anything. So same thing you need to understand that there are some clinical factors which are involved in establishing a rapport with the patient. 1/3 of the drug effect is just doctor-patient relationship. So that is also important pharmacokinetic parameter. But we were discussing this. The only subject you have been told is cardiology, and you are very well aware now how much cardiology you've understood. So try to revise. You will find all these points there. In cardiology, the first complaint is chest pain. That is cardiology beginning. So third point, third drug that we come across is phenyldopam. Simple drug, phenyldopam. Phenyldopam is simply a D1 agonist. It's a vasodilator. D1 receptor are vasodilators. So it decreases BP. And therefore, the only use of this drug is hypertensive emergency. Because the drug is catecholamine, so it will be given only in IV route, hypertensive emergency, no other use. Phenyldopam. Vasodilator, only IV, so only for hypertensive emergency. 3 drugs are over. The next 3 drugs are very, very important, and we'll discuss them in detail. So we come to adrenaline, noradrenaline, and isoprenaline. These 3 drugs, very important. We'll discuss their effect on blood pressure. So you can have the systolic blood pressure and the diastolic blood pressure. Now let us see. Adrenal with an A starts with A for all. Adrenal acts on all the adrenergic receptor, alpha 1, alpha 2, beta 1, beta 2. A for all. So alpha 1, 2, beta 2, all adrenergic receptor stimulates. NA is not all, noradrenaline, not all. So noradrenaline acts on alpha 1, alpha 2 and beta 1. It does not act on which receptor? Beta 2. So which action it cannot produce? It does not act on beta 2. So vaso, broncho. So no beta 2 action is there. Isoprenaline acts only on beta 1 and beta 2. It does not act on alpha receptor. No alpha action is there with isoprenaline. This is the difference between these 3 drugs. A for all, not all, and iso means same, so it acts only on same receptor beta, not on alpha. We are trying to understand their effect on blood pressure, systolic and diastolic. Systole. What happens in systole? What do you call systole? Heart. Which receptor is involved in contraction of heart? So systolic BP is a function of beta 1 action. Any drug which stimulates beta 1 will increase systolic BP. All the 3 drugs, as you can see, act on beta 1. All of them increase systolic BP. They all act on heart, systolic BP goes up. Diastolic BP. Diastolic BP. What is diastole? Heart is relaxing. So why doesn't BP fall to 0 during diastole? Heart is relaxing. So BP should fall to 0. But does it fall to 0? So what maintains BP during diastole? Blood vessel. Blood vessel remain constricted. So which receptor is there on blood vessel? Alpha 1. Anything else? Beta 2. So net influences constriction. Adrenaline. Look at adrenaline. Does it act on alpha 1? Adrenaline, does it act on alpha 1? Does it act on beta 2? So some blood vessel will constrict, some will dilate. Overall, there is no major significant change in which BP. So if you are asked, adrenaline does not affect which BP? Answer is, like there are 3 BP. Systolic, diastolic and mean BP. What is mean BP? Mean BP is 1/3 of, you always remember things in a wrong manner. 1/3 of which BP? Systolic and 2/3 of, that is mean BP. 1/3 of systolic and 2/3 of, because in a cardiac cycle 1/3 time is systole, 2/3 time is diastole. So if systolic BP is going up and diastolic is remaining same, so what will happen to mean BP? Systolic is going up, diastolic is remaining same, so what will happen to mean BP? So which BP is not increased by adrenaline? Diastolic. It increases systolic, it increases mean BP, but not the diastolic. Come to noradrenaline. Noradrenaline acts on which receptor? Does it act on beta 2? So throughout the body, which vaso will occur? So diastolic BP will shoot up. Tremendous rise in diastolic BP. Excessive vasoconstriction. Look at isoprenaline. Isoprenaline acts only on, so only vaso, but diastolic BP will has to go down. Clear? So now if I ask you, these are 3 drugs. If I ask you now that which is the best drug out of these 3 to increase BP, what will you say? So you have discovered the use of noradrenaline. It is the drug of choice for any kind of shock. In general, if there is shock, which is the first drug you should think of giving? Okay. Acute hypotension or shock, you want to increase BP. Which is the drug? Not. It increases both systolic and diastolic BP and now obviously mean BP. While the other 2 drugs you can see will not have that much increase in BP. So noradrenaline is basically a vasopressor. It is a drug to increase BP. So if you are looking at a case of hypotension, then the first thing we try generally in ICU, if you go, first thing they will give is high dose of dopamine that you have discussed earlier. If not controlled, NORAD. If not controlled, last option is vasopressin. If not controlled, then prayer. Okay, that is why ICU are built on the top floor. Generally the OPD is on the ground floor. Most of the patients go home. They are admitted on first floor. Some of them go home, and ICU is on the higher floor because chances of going up are high. As you move up, you go up. In India, you go to ICU. A patient comes to ICU for varied reasons: renal failure, post-MI, GI hemorrhage, post-surgery. But once in ICU, if patient comes out of ICU within 2-3 days, then he is okay. If he spends more than 2 days in ICU, in Indian ICU, then things change. He gets the complimentary Pseudomonas with compliments from the hospital, nosocomial infection, because the catheter, the central line, the IV fluids and all these machines and ambu bag, the ET or something, somehow infection keeps him. And patient develops fever by day 3. Fever is going into sepsis, there is widespread infection, sepsis, hypertension, now patient's oliguria. Forget why he came into ICU, renal failure, diabetic coma, whatever. Now focus on BP and urine, BP and urine, BP and urine. So by 3 days, every patient, I'm generalizing, but most of the patients will find themselves on drip of dopamine and noradrenaline. By day 5, cases almost, in most of the cases, done. Because patient has gone into multi-organ failure. When BP falls, kidney goes away. When kidney goes away, toxins are not going, then brain goes away, then multi-organ failure, and then if you are lucky, very lucky, you will come out. Otherwise, kissa khatam. So that is why these drugs are very, very important. Dopamine, high dose, low dose, noradrenaline. Now we come to heart rate. BP effect I have told you. Come to heart rate. Heart rate will be of two types. There will be a direct action on heart rate. There will be something called as reflex action on heart rate. And some of these two will give us net action on heart rate. So we need to discuss this. Very, very important. So below this table, we need to understand. Below the table, draw a diagram. This is our heart. And heart is having, as discussed, beta 1 receptor. Any drug stimulates beta 1. What will happen to heart rate? So that is called direct action on heart rate. Come back to the table. Direct action on heart rate is nothing but beta 1. All the three drugs have beta 1 action. So all of them directly increase heart rate. Clear? All of them directly increase heart rate. They go to heart, act on beta 1, try to speed up the heart. Now we need to understand what is this reflex action. Direct action I have told you. I hope that is clear. It is the direct action on heart through beta 1. In order to understand the reflex action, focus on the blood vessel. This is a blood vessel having, suppose, alpha 1 receptor. Now the drug is acting on alpha 1. So is alpha 1 present in heart? Is alpha 1 present in heart? So drug has no direct action on heart. Drug is acting on blood vessel causing vasoconstriction, alpha 1 agonist. So when vasoconstriction will happen, what will happen to the diastolic BP? It will increase. This vessel will constrict, alpha 1 stimulation, diastolic BP will go up. There is a receptor in the blood vessel that is called as baro receptor. Baro means pressure. This receptor is there in the blood vessel to sense pressure. It's a pressure receptor. Now 2/3 of the time in the blood vessel, which pressure is there? So in a cardiac cycle, 2/3 of the time is spent in what? So 2/3 of the time, which pressure is there? Which has increased. This receptor senses, oh, diastolic BP has increased. It will send a signal to CNS. What is that signal? Diastolic BP. That is the function of receptor, to send signal to CNS. Brain or CNS? How brain is connected to heart? Brain is cranium. Understood? Cranium. This is your brain. This is your heart. How they are connected? Through vagus. Which kind of nerve? 10th cranial nerve. You remember cranial nerve 3, 7, 9 and 10. It comes to heart. Brain calls vagus. Brain increases vagal activity. Vagus goes to heart. Releases what? I told you it's a parasympathetic nerve. It will release what? Cholinergic. If you recall, what were the receptors of acetylcholine at organ level, autonomic organ level? Which receptor? How many types of acetylcholine receptor did we talk? Nicotinic and which of them were present at the organ level? Muscarinic. So vagus will act on muscarinic receptor through acetylcholine, and if you remember the cholinergic or the vagal or the parasympathetic action on heart, what was that? What happens when parasympathetic stimulation on heart? Sympathetic stimulates heart, parasympathetic inhibits heart, and heart rate falls down. This is the reflex contribution or reflex control of the heart rate. In short, whatever happens to diastolic BP, reverse happens to heart rate. We can take another example. Suppose there is a vasodilator. So when vasodilator is there, diastolic BP will, there is a drug which is a vasodilator. So diastolic BP will vasodilator. So pressure in the blood vessel will, so barrow, pressure has, so signal going to brain will, but there is no signal to be formed. So signal going to brain will not stimulate which nerve? Heart rate will. So whatever happens to diastolic BP, reverse happens to heart rate by which reflex? Which is this reflex? So this is what you have to remember. Diastolic BP falls, you're looking at reflex tachycardia. Diastolic BP goes up, you're looking at reflex bradycardia. Understood? Through which receptor? Baroreceptor. This is the pathway, but this is the nutshell. Do you know the changes in diastolic BP? With these three drugs, do you know the changes in diastolic BP? We know it. This is what is the changes. So can you tell me what will be the reflex action with each of them? Opposite of this. So what is adrenaline doing to diastolic BP? What is adrenaline doing to diastolic BP? Nothing. What is the opposite of nothing? Nothing. So overall heart rate will increase. Directly it is increasing, reflexly nothing, so heart rate will increase. Look at isoprenaline. Look at the third drug, isoprenaline. What is isoprenaline doing to diastolic BP? So reflexly what will happen to heart rate? So what will happen to overall heart rate? So now increase in heart rate is same as adrenaline or more than? So now you know that isoprenaline is a drug to increase heart rate. Patient comes with bradycardia. Patient comes to you in emergency with bradycardia. Heart rate is low. Which of the three drugs should be used? Isoprenaline. NA is the drug to increase BP and isoprenaline is the drug to increase heart rate. So what will be the use of isoprenaline? Bradycardia. It is not a drug for shock, but it is a drug for bradycardia. What is adrenaline doing to BP? Slight increase in BP, slight increase in heart rate. Both you can see. So patient comes with cardiac arrest. Cardiac arrest. What is happening? In movies you are shown that pulseless. Patient has become that pulseless. BP is also low, heart rate is also low. You want to increase slight BP also, slight heart rate also. Which is the drug? Adrenaline. Come to noradrenaline. Noradrenaline, what is happening to diastolic BP? You are shown excessive. So reflexly what will happen? Excessive decrease. So overall what will happen? Tell me. Directly there is increasing, reflexly 3 decrease, 1 increase, 3 decrease. Overall bradycardia. Look at the receptors of Na. Look at the Na receptor. It is a beta 1 agonist or antagonist? Noradrenaline. Beta 1. What it should do to heart rate? What do you think it should do? But when you give Na to a person, heart rate actually decreases because of strong reflex inhibition. So is Na useful in a patient of bradycardia? No. It is useful only in a patient of hypotension. So now you understand Na is a drug to increase what? BP. Isoprenaline is a drug to increase what? And adrenaline is a drug to increase both of them small. So hypotension, bradycardia, cardiac arrest. Okay. Now, suppose now there is a patient who has a normal heart, like I am. If you give Na to me, what will happen to my heart rate? Decrease. Clear? I fell in love with a girl and obviously she did not like me. It was one-sided love anyhow. She did not even know, like happens in medical college. So she, after some time of one-sided love, I thought she has dumped me. But the girl is unaware that somebody in boys hostel is in love with her. So love happened, heart also broken. So my heart was broken. So I decided to go for a donor heart. Okay. So transplanted heart. My heart was broken, so I got a new heart. So now you tell me, transplanted heart transplantation is possible nowadays. In heart transplantation, we can join the vena cava, aorta, all blood vessels. But can we join the vagus to the donor heart? So vagus is not connected to the donor heart. So now can the reflex action come? Look at the diagram which we have drawn below. Look at the reflex pathway. You have the reflex pathway. So in transplanted heart, vagus is broken. So which action cannot come? Reflex. But even the donor heart has beta 1. So which action will come? Direct. And what is the direct action of Na on heart rate? So now we will write a few points. Number 1 point, Na on normal heart causes bradycardia. Na on an individual with transplanted heart. Now what will it cause? Reflex pathway is broken, but the direct action remains tachycardia. Na given after atropine. What is atropine? Anti-muscarinic. Come back to the diagram. Can you locate muscarinic receptors? Can you locate muscarinic receptors? Block them. Atropine. Can vagus act now? Vagus is acting by which receptor? It releases acetylcholine. Acetylcholine acts on which receptor? Which you have blocked. So now which action again gone? Reflex action is gone. So again it will cause tachycardia. These are the questions asked. Na in a normal person will cause bradycardia, but in a patient with transplanted heart, or if Na is given after atropine, it will start causing tachycardia. So these kind of questions are not very commonly asked. I will not say they are commonly asked, but sometimes they have been asked. So you need to remember the actions of these 3 catecholamines on these parameters: BP, heart rate. Clinically important points I have told you. So we will just write the use of Na. Noradrenaline. You can say it is drug of choice. Everybody is fond of drug of choices nowadays. Drug of choice for, you can say, acute hypotension or shock. Nothing is specified. You are looking at a condition where BP is falling, which is the drug Na. Na is catecholamine, cannot be given by which route? Oral. So we have developed an oral prodrug. Oral prodrug of Na. A prodrug that converts into Na in body given orally, that is called droxidopa. So droxidopa is the prodrug of what? This question is asked. What will you answer? But if this question was asked 5 minutes earlier, what would have been your answer? So please understand, droxidopa is a prodrug of, first option is always, in the question first option is always dopamine. So what is the rule in MCQ solving? If you have no clue about anything, there is an MCQ about which you have no idea, you're reading it for the first time. You read the question, and out of the option you think this is the answer. Like droxidopa is a prodrug of first option dopamine, you think this makes sense. That is never the answer. So if you don't know anything about a topic and you read the topic question and then some logic you apply and you come to an answer, that is never the answer. And if you have read something previously, you have read something like this, I have told you now, droxidopa is a prodrug of. You have read, but you have forgotten. Obviously, we forget. Now this question comes in exam. The first instantly answer that strikes is Na. But then you think, no, let me think. I read it, there was some chakkar here, something was there. I don't remember, but sir told there was something, exception or something. So droxidopa, Na, adrenaline, it should be dopamine, La, levodopa, droxidopa sounding similar, answer should be dopamine. But your instant reaction was Na. But now you have used your mind and come to a conclusion of dopamine. That second conclusion is always wrong. So there are two things. If you have not read anything previously, MCQ comes, you apply logic, come to an answer, that is always wrong. You read something but you have forgotten. That information is there in your subconscious mind. You read the question now and your subconscious is trying to tell you this is the first instinct is always the correct, but then you will think, let me remember, let me think. You think, apply some logic, come to an answer, that is always wrong. So these kind of tricks you have to practice while you are appearing in what we encourage grand test, mock test. They are not for the questions that may come as such in exam. They are for you to understand how to avoid silly mistakes, how to handle the exam pressure, how to arrive or increase the probability of correct answer even when you have no idea about the question. So by all these practice, if you are able to solve even 2 extra questions, then you score 10 extra marks. 4 positive, 2 negative that you have avoided, and 10 extra marks can move your rank from 50,000 to 2,000. So take all the tests, grand test, mock test seriously, whether you are prepared or not prepared. Like you are in starting phase of your preparation. You will study subjects. Most of the subjects you have not studied in detail. So you think you will appear in grand test when you have done some subjects. Maybe in September, October. Even at that point of time, believe me, you will face the same problem. That I have studied 10 subjects, but 8 of them I have forgotten. So I remember only 2. So I will do grand test when I will do revision. So now it is postponed to December. In December, I do not have time for grand test because I have to revise so much. Half of things that I have studied, I am not having time even to revise. You are talking of grand test, mock test, I don't have time. So those who want to use the grand test, mock test should start from now on at least once a month. In July, August, you should do at least 1 grand test. In September, October, every twice a month, and then probably in December or near to the exam every week. Whether you know the topic or revision is done or you score 10% or 100%, you appear in the exam. If you are consistently scoring below 40% in the grand test, you started with 15% in June, by December also you are somewhere around 35%. Don't be in any illusion, you are not getting selected. Others are not fools. Those who are preparing with you scoring 75, 65%, they are not fools. They are not going to commit suicide in exam. No miracle is happening. So you should be mentally prepared that this year probably we need to work more. If your performance has improved, in June you were at 15%, but now you are around 55%. You have chances of selection. in the last moments or last days, try to give maximum. You are almost there. On the day of exam, things can work for you. If you avoid silly mistake, paper is relatively simple, you can get through. And if your performance was good, 20% in June you are scoring, now you are scoring consistently about 60%, 70%, then you need to keep up that pace because you are almost selected. If you continue to work hard, you will get a very good rank. So it gives you an idea where do you stand. How much have you improved? What is going to happen on the day of exam? So you know. So those who are very low scorers, they should not feel bad after the exam. They know it. Next year, they will get the chance. Those who are on the margin, they need to understand that in last 7, 10, 15 days also, they can do something, probably study for more hours, crack the exam. And those who are already doing good, they need not be complacent, because if they become complacent, if they relax, their rank will go down. And then they will repent that I've studied for 6 years. In the last 6 weeks, I became lenient, and now my rank, which could have been within first 500, is now 2000. So it is very important to plan. You know, your time is precious. We teach an Indian student for 20 years. Since the time you were born, or since the time you can recollect, what have you done in life? What is the major achievement in our life at this point of time? You have only studied. Initially in schools, then medical colleges, some of you have been toppers throughout. All of them is useless. This is the exam. What will you do for rest of your life? Whether you will become a surgeon or not depends on this exam. If you do not get MS surgery, in India, nobody is going to let you enter the OT. If you get a good rank and get, let's say, pediatrics, then only you will get the chance to treat children, otherwise not. If you get a good rank and you are not interested in night duties or clinical practice, you can go for radiology, only then you will get a radiology. So whatever you have done till now, how much you have studied is going to be dependent on this exam. If you perform nice in this exam, then you can choose the work that you will do for rest of your life. If you do not perform in this exam, then you will be forced to do the work that others have left for you. So others have not picked up ENT, Opthal, Derma, whatever branch, you choose from that. So this exam is very, very, very important. And that is why it is important to take it with utmost seriousness. Whatever seriousness you have, you just think of that this is the exam for which you have been studying so far. So there are students who fail in every test of MBBS. From the anatomy spotting till the final year exam, they have not passed any exam in one attempt. They are classical failures. They fail every time. After some time, they take pride. I will fail. But in internship, they realize that enough of failure. Or post-internship, whatever. One day they decide to study. And then they study for 6 to 8 months with focus. And then they clear pre-PG in first attempt with good rank. And now everybody is like, he was intelligent, always smart. I knew it. He was my friend. I always knew he's a smart guy. He did not study. Now he studied. And on the other hand, there is a student who is a good throughout the MBBS. But somehow, he does not get a rank in PG exam. What do people say? He was a bookworm. Did not have intelligence. I knew from the very beginning. He was next roommate. He cannot perform in life. So, you do not want to be in the other category. People perception change. In India, this is the exam that will decide your life. You give your best shot and you will find all the sins of the past will be washed away. You go to good college with good branch, all you have to do is solve few more MCQs. How MCQs are solved? By revising the same points again and again. For what? What is needed? You have the notes, just sit throughout the day as much as you can, read them again and again. That's all. It's a hard working job, not a very intelligent work. Anybody can do it. And if you are not able to clear in, let's say, this exam, after 6 months, another exam will come. After 6 months, another exam. Just keep on doing it, you will clear it. So if you clear in first attempt, which we should try, it is very good. Unfortunately, if it doesn't occur, do not lose heart. There is always a next time. Okay, you will all live for 80, 90 years. Average lifespan in India is now 70, 75 years. Average. And we are educated, health-wise educated, doctors, better health facility, access. So you will definitely live, unless some accident happens, you will live for 80, 90 years. So in that lifespan, 6 months do not matter. So try to understand things and try to get a good rank so that you choose the work that you do in rest of your life. Okay. So somebody likes treating children. Somebody likes it. He is very sympathetic to children. When children come with disease, he wants to help them. On the other hand, somebody is action oriented. He does not understand what is the difference in treating child and a dog. I am asking him, what happened? He is crying. Feeling pain, crying. He is having diarrhea, crying. He is overfeeding, crying. Underfed, crying. Fever, crying. Only time he says is crying. Why, what happened? Are you feeling this? Crying. That, crying. What to do with this? Somebody likes slap child right now. And such a student who does not like treating children, for example, goes and takes pediatrics, what do you think he'll do? Somebody is 40 kg person, upper, thin, he only study 40 kg is his entire weight, gets the first rank orthopedics, goes into OT. What do you think is happening in orthopedics OT? You have all been, it's a mechanical job, nailing, retracting muscle, using the, REs and all, hammer, and his third day he himself has, radius dislocation. Somebody is very analytical. Patient comes with complaints, he thinks what is the differential diagnosis, this, which history should I take, which question should I ask. He takes up radio diagnosis. What will he do? Just seeing the images, making the diagnosis, half of the time even the technician gets. So you can choose the branch according to your performance, your personality, if you get a good rank. That's all I'm trying to say. If you choose the work that you like, you will be a good doctor. If you are forced into a work that you do not like, you will not be a good doctor. So that is why this is important. So next time you feel too much sleepy, just think about these points and you will find some motivation. That is what we want to do. So LA uses, I have told you, droxidopa can be given orally for the treatment of what we call as orthostatic hypotension. Orthostatic hypotension is hypotension on standing. Which drug can be used? Droxidopa. If you are asked what is the drug of choice for orthostatic hypotension, then droxidopa is not the answer. Answer is a mineralocorticoid called fludrocortisone. Fludrocortisone is the drug of choice. So keep writing the drug of choices. Droxidopa can be used as a vasopressor, but drug of choice is fludrocortisone for orthostatic hypotension. It's a mineralocorticoid, fludrocortisone. NA uses are over. Isoprenaline, I have already told you. Isoprenaline, it has practically only one use. It is used in cases of bradycardia or heart block. If you are asked what is the drug of choice for these situations, the drug of choice is again not isoprenaline. Drug of choice will be the itropin. So there are two drugs available to speed up the heart. The best is atropine, second is isoprenaline. There are only two drugs to increase the heart rate. These are the two drugs. Then we come to uses of adrenaline, very, very important. Adrenaline uses, very, very important. We will draw a table. We will write what is the use. Second is we will write what is the route of administration. Third, we will write what is the concentration. Three things you will write. The first use of adrenaline, number one, is anaphylaxis or anaphylactic shock. Both are same thing, anaphylaxis or anaphylactic shock. The preferred route here is intramuscular. Intramuscular is the preferred route. In anaphylaxis, the concentration is 1:1000. What is the meaning of this 1:1000? You need to understand 1:1000. 1 refers to gram. 1 gram dissolved in 1000 ml. 1:1000. 1 gram of adrenaline dissolved in 1000 ml of water. 1 gram in 1 liter. 1 gram is equal to how many milligrams? 1000 milligram in how much ml? So this means 1 milligram per ml. That is the meaning of 1:1000. So you take 1 milligram of adrenaline, dissolve in it 1 ml of water, inject it by which route? That is the life-saving measure in which disease? Anaphylaxis. 1 gram of adrenaline, 1 milligram, sorry, dissolved in how much ml? 1 ml, given by which route? IM. And how much dose, if you want to know? Have you understood this 1:1000? 1:1000 simply means what? 1 milligram per ml. You can write it below also. And third point you can write here, how much is the dose given? Dose given in anaphylaxis is 0.5 ml at one shot. So 0.5 ml of this concentration means how much milligram of adrenaline are you giving? So 0.5 ml of 1:1000 concentration given IM is the life saving in anaphylaxis. Then the second use of adrenaline is cardiac arrest. Now the preferred route is IV. Whenever we give IV adrenaline, there is a risk of cerebral CNS bleeding, CNS hemorrhage. That risk we take. IV adrenaline always carries the risk of cerebral hemorrhage, CNS bleed. So we want to decrease the risk, so we dilute the solution. Whenever we give IV, we make it 1:10,000. 10 times diluted. What does it mean now? 1:10,000. This will be 0.1 milligram per ml. So now if I ask you, see, this is how questions are asked. You are in emergency. Patient comes with anaphylaxis. Which solution is available? 1:10,000. Only 1:10,000 solution is available. Now you tell me how much ml of adrenaline will you give? So patient is of anaphylaxis. You want to give IM. Best is 1:1000, but that is not available. What is given in the question? 1:10,000. Question is asking how much ml of adrenaline will you give? Reverse. Patient comes with cardiac arrest. Suppose that is the solution available. How much will you give? So this kind of conversion can be asked. The dose in cardiac arrest generally is 1 milligram of adrenaline has to be given. So tell me now, how much ml of adrenaline will you give here? In cardiac arrest, IV 1:10,000, how much ml? 0.1 milligram is present in. So 1 milligram will be present in 10 ml. These kind of questions are asked. Third use of adrenaline, which is of importance, is what we call as adrenaline is mixed with local anesthetics. Route is subcutaneous and the concentration is a very dilute concentration, 1:2 lakhs. So you are asked nowadays, match the following. Indication is given, route is given, concentration is given. So 1:1000 is for which indication? Anaphylaxis. Which route? Same is true. Same can be given in status asthmaticus also. The route can be IM or even subcutaneous. Minus 10,000 is for IV cardiac arrest. 1:2000 is with local anesthetics. These are the important uses of adrenaline. Fourth use of adrenaline, you can write dipivefrin is a prodrug of adrenaline. It is given in eye drop form, and this is used in treatment of glaucoma. So in treatment of glaucoma, we'll discuss in detail. Adrenaline and dipivefrin are used in treatment of glaucoma, given as eye drops. So that will take up in glaucoma when we go there. So these are the uses of adrenaline. Concentration, everything is done. Catecholamines are done. 6 catecholamines, one by one, all I have told you. Very important topic, and we have discussed at length. So dopamine, dobutamine, phenyldopam, and the 3 with effects on BP and heart rate and the uses. So let's go to the classification. You see the classification of drugs. We are discussing which kind of drugs. Directly acting, catecholamines are done. What is left? Directly acting non-catecholamines. These are very simple now things, not will require your much of time. Non-catecholamines, still direct acting. So we can discuss them one by one. Drugs which are alpha 1 agonist. Drugs which are alpha 1 agonist. Number 1, phenylephrine. Phenylephrine, alpha 1 agonist. It can be given as eye drop. E/D is eye drop. You put in eye drop, it causes mydriasis. So it's a mydriatic which will not cause any cycloplegia. No cycloplegia. What is cycloplegia? We will discuss later. Mydriasis without any cycloplegia. Phenylephrine, if given IV or oral, can be used as a vasopressor. Vasopressor will be used in treatment of shock. These are 2 uses of phenylephrine. Then you have drugs like methoxamine, midodrine, mephentermine. Again, these drugs are used as vasopressor, as a vasoconstrictor. Again, for treatment of shock. You can have xylometazoline, oxymetazoline. These drugs are used or given as which form? Nasal drops, and they are used as nasal decongestant. Nasal decongestants. You put Otrivin drops, I'm sure everybody has seen or used. They constrict the nasal mucosa and the congestion goes away. These drugs have side effect of causing rhinitis, medicamentosa on chronic use. They can cause atrophy of the nasal mucosa on chronic use. Do not use them for long term. Use them for short term. Among these, there was a drug called phenyl propanolamine. This was also a nasal decongestant. This drug has been banned because it was found to cause hemorrhagic stroke. It was causing CNS bleeding. The drug has been banned. Very commonly asked question: which drug causes stroke? Which drug causes stroke? Answer is phenyl propanolamine. The drug was used as a nasal decongestant. So this is not available in market anymore. These are simple alpha 1 agonist. So alpha 1 agonists are used as what? Vasopressors, also mydriatics, and also nasal decongestant. We come to alpha 2 agonist, very very important. There is a long list. Alpha 2. Let's first revise what we know about alpha 2. Alpha 2 agonist, they will decrease which release? NA release, and that would lead to sympatholytic action. From CNS, sympatholytic action. There are several drugs in this category, several drugs. Now you see an NA release decreases. Where in CNS? There are several effects. Number one, what happens to blood vessels? Vasodilation. Vasodilation will be used as which effect? Antihypertensive. When NA decreases in CNS, what is the effect that happens? First effect that happens is vasodilation. Sympathetic activity decreases, blood vessel dilate, antihypertensive. Which kind of antihypertensive? As I explained earlier, centrally acting. Which is the drug comes to your mind? Clonidine. What is the major mechanism of clonidine action? Alpha 2 stimulation. But it also has one more action, that is called imidazoline receptor stimulation. There is another receptor in CNS called imidazoline receptor. That also it stimulates. Imidazoline receptor stimulation. The clonidine has two mechanisms. Alpha 2 stimulation in CNS also stimulates another receptor called imidazoline. That's also a CNS receptor. Why this is important? Because you will come across a drug called moxonidine. Moxonidine acts only on imidazoline receptor. Again, this is a centrally acting antihypertensive. So centrally acting antihypertensive are of two types. Drug which acts predominantly on alpha 2, that is clonidine, and drug which acts predominantly on imidazoline receptor, that is moxonidine. Both are presynaptic receptor in CNS, both cause vasodilation. Imidazoline, alpha 2. Moxonidine. Second, when NA releases or when NA release decreases in CNS, what is the second action? Sedation. You feel sleepy. And right here, what are the effects which will happen? Effect number 1, vasodilation. Effect number 2, sedation. So tell me, What is the most common side effect of clonidine? Sedation. Most common side effect of clonidine. Clonidine is given for which disease? What problem it causes? Sedation. Which drug is acting on CNS, decreasing BP but not on alpha 2? Which drug is acting in CNS, decreasing BP but not acting on alpha 2? Moxonidine. So which problem will be less with moxonidine? Understood? So moxonidine has less sedation. That is the advantage of moxonidine. Okay. Imagine a patient in ICU. ICU patient with already respiratory depression. The patient is already on ventilator. Imagine COVID. COVID is basically a respiratory disease. The patient goes on ventilator. Patient is in ICU. Unable to sleep. Because of pain or any other reason, he is unable to sleep. Which drugs do you know are given for insomnia? What are the drugs? If you do not get sleep, what drug do you take? Diazepam, clonazepam, barbiturates. Okay, so imagine a patient who is in ICU, he is very sick, he is having respiratory depression, but he is unable to sleep. So what are the normal sedatives? We have two classes, diazepam, benzodiazepines and barbiturates. Both of them can cause sedation, but they cause respiratory depression. The patient is already having respiratory depression. We need a drug that will cause sedation without any respiratory depression. So we have developed an alpha 2 agonist by the name dexmedetomidine. So dexmedetomidine is used as a sedative in patients with respiratory depression in ICU. So it is also alpha 2 agonist used as a sedative now. Clear? For clonidine, it is a side effect, sedation. Clonidine is an antihypertensive drug. For clonidine, sedation is the side effect. For dexmedetomidine, that becomes the used very commonly asked drug. What is the advantage? Sedation without respiratory depression. Third, when Na decreases in your CNS, you have muscle relaxation. Muscles also relax when Na reduces in your CNS. So we have developed a drug by the name tizanidine. Tizanidine is an alpha 2 agonist which is used as a muscle relaxant. It is used to relieve muscle spasm in specific condition. When your back muscle undergoes spasm, whether cerebral palsy or trauma or any other, we can give tizanidine to relieve the muscle spasm. Acts on alpha 2 in spinal cord, increases any release, causes muscle relaxation. When Na decreases in your CNS, you have anxiolysis, anxiety decreases. Already we have seen Na release decrease causes sedation. Already we have seen it causes muscle relaxation. All these properties are useful where? All of them combined are useful. You want muscles to be relaxed, you want sedation, you want anxiety to decrease, where all these properties are needed. Anesthesia, so alpha 2 agonists are used as add-on drugs in anesthesia. So clonidine like drugs are used in anesthesia also. They do not cause anesthesia, but they decrease the requirement of sedative, decrease requirement of muscle relaxant, decrease the pre-operative or post-operative anxiety. When Na decreases in your CNS, you also have analgesia. Pain also reduces. So this makes clonidine. It was tried earlier for treatment of migraine. Now it is not used, but it was tried. It was used earlier in migraine also, clonidine. In previous editions of the book, you will find migraine also. Finally, when Na reduces in your CNS, it decreases the withdrawal reaction. The withdrawal reaction decreases, withdrawal symptom decrease. So this is used in opium withdrawal, WX for withdrawal. We have developed an alpha-2 agonist for management of opium withdrawal. That can be a drug called lofexidine. Lofexidine, alpha-2 agonist used in management of opium withdrawal. Decreases withdrawal reaction. So there are several alpha-2 agonists which are written. All of them act on alpha-2 in CNS, central nervous system. Decrease Na release. When Na goes down in your brain, blood vessel relax, you feel sleepy, muscles relax, you feel less pain, less withdrawal symptom. Okay. So this is about alpha-2 drugs acting in CNS. Rebound withdrawal, rebound hypertension with clonidine we have already discussed. So alpha-2 agonists, most of them I have told you. Now come to beta-1 agonist. Alpha-1, alpha-2 we have done. Beta-1 agonist. Beta-1 agonist, you have already done dobutamine. It was done under catecholamines. There is no other beta-1 agonist that we need to study. We come to beta-2 agonist. Beta-2 agonists are pretty simple drugs. Drugs like salbutamol. They are used for treatment of asthma. We'll discuss them in detail in asthma. Drugs like ritodrin and isoxaspirin. Ritodrin, isoxaspirin, they are used as tocolytics, and tocolytics are used for treatment of tocolysis, relaxation of uterus. Why do you want to relax uterus? For preterm labor. So this will be covered in detail, this activity in detail in ONG. Obstetric people will teach you everything about birth and related drugs. And third is a drug called nilidrin. Nilidrin can be used as a vasodilator. These are beta-2 agonists. Nilidrin is a vasodilator, not very important, not discussed. Tocolytics will be discussed in detail in the OBG. Salbutamol we will discuss tomorrow in chapter on asthma. Not to be discussed here. All directly acting drugs I have told you. All directly acting drugs. Catecholamines and non-catecholamines. So these are the drugs which act directly on alpha or beta receptor. Only thing you have to understand here is catecholamines, rest are not important. Now we go to the second type, that is the indirect acting. Indirect acting drugs. As the name suggests, these drugs will not act directly on the receptor. Indirectly acting. So how do these drugs act? That is first you have to understand. There are three important mechanisms. Draw the diagram of the synapse. Try to understand the mechanisms. The vesicle is filled with Na. Na is number one, released. Then Na can act on its receptors present after the synapse. They can be alpha or beta. It acts on them. Then what happens to Na? What happens to Na? Once it has acted, does it continue to act forever? No. So Na is taken back. Na goes back in the neuron. Which is this process called? This process is called reuptake. So action of Na is terminated by which process? How action of Na is terminated? It is taken back by which process? Reuptake. For reuptake, there is a protein which is involved through which Na goes back into the neuron. This protein is called norepinephrine transporter, NET. So Na goes back by which transporter? NET, norepinephrine transporter, NET. So now just imagine that we are giving a drug. Drug comes and inhibits NET. So drug is simply a norepinephrine transporter blocker. So which process will stop? Which process? So we can say reuptake inhibitor. So where will Na remain? Where will now Na remain? In synapse. An action of Na will. So which substance, now listen carefully, which substance will stimulate alpha or beta receptor? Na. The drug, does it act directly on alpha or beta? No, so indirect action. Drug is causing what? Inhibition of reuptake. Na remains, Na acts. Drug is not acting on alpha or beta directly. Your drug is not stimulating the receptor, that is why the drug is called indirectly acting. So first mechanism of indirect action is which inhibitor? Reuptake inhibitor. Reuptake inhibitor inhibit which protein? Norepinephrine transporter. Once you have understood this, the drug's name you can write tricyclic antidepressant. Tricyclic antidepressant will be used or studied in detail in the chapter of depression. Not here, but they are Na reuptake inhibitor. Then you will discuss there is a drug called atomoxetine. Atomoxetine is one of the drug used for ADHD. It's not drug of choice, it is also Na reuptake inhibitor. Increases Na, decreases hyperactivity. Okay, ADHD. We'll discuss ADHD in detail. Third is a drug called modafinil. Again reuptake inhibitor used for narcolepsy. Narcolepsy is excessive sedation. It is drug of choice. We'll discuss narcolepsy in detail. So modafinil will come back. It increases Na. When Na increases, you see it's very simple. When Na is decreasing, you are feeling sleepy or active. Alpha 2 we have done now. Na was decreasing, so you are feeling sleepy, sedation. Now Na is, so you will feel active, less sedation. What is narcolepsy? Excessive sleep. So modafinil increases Na, sleep goes away. Fourth is cocaine. Now cocaine is something that we will discuss here in detail. Cocaine. Now cocaine resembles which drug? Name of cocaine. Looks like lignocaine, xylocaine, procaine, cocaine. So what is this drug? The drug is basically local anesthetic. That is the main activity of cocaine. Plus, it is a sympathetic drug. So it has two actions. It's a local anesthetic, plus it is sympathetic. Local anesthetic means drug is a sodium channel blocker. All local anesthetics have only one mechanism to block sodium channels. And sympathetic, the drug is NET inhibitor, reuptake inhibitor. So it has two actions. It blocks sodium channels on nerves, local anesthesia, and it blocks the reuptake of Na, increasing Na sympathetic action. What questions are asked on cocaine based on this property, sympathetic property? Number 1, cocaine sniffer. Cocaine is abused, drugs of abuse. It is sniffed. Some drugs are inhaled, some drugs are smoked, some drugs are injected. Cocaine, I'm sure you have seen in the movies nowadays. It is a powder. People draw lines and they sniff it. So where is the cocaine going? When you sniff, the drug is going in nasal cavity and palate. It's a sympathetic drug. Sympathetic drug will cause vasoconstriction. So blood vessels of the nose and palate, they undergo vasoconstriction. Blood supply. When there is vasoconstriction, blood supply to nasal septum and palate will decrease. Less blood supply, mucosa will grow or atrophy. So perforation. So septal, nasal septal perforation or palatine perforation is a classical sign in cocaine sniffers. Septal perforation, palatine perforation because of continuous vasoconstriction. Overdose, all drugs of abuse. One day patient will take too much. All drugs of abuse, whether it is alcohol to cocaine or morphine to cannabis, one day the abused addict patient will take more than what he can tolerate. So cocaine overdose, what will you find? It's a sympathetic drug, so BP will high or low? High. Vasoconstriction, BP has to go up. What will happen in eye? It's a sympathetic drug. Meiosis or mydriasis? So mydriasis. The moment question says the patient came with meiotic pupil or constricted pupil or pinpoint pupil, which poisoning is not possible? Cocaine poisoning. Sympathetic poisoning is not possible. Okay, so to look into the eye. Third, in cocaine only addict, I am telling you there is one more property not related to sympathetic, but I'll tell you. Cocaine bugs, have you heard? Patient feels tactile hallucination, that insects are crawling on his body. So when insect is crawling, what will you do? So scratch marks. So in a patient with history of addiction, if you are given three things, hypertension, dilation of pupil along with scratch marks, this is a classical case of cocaine addiction. Okay, so these are points which are asked in cocaine. These are reuptake inhibitors, the first mechanism of indirectly action. Understood? Narcolepsy, etc. will come to detail again. These are indirect reuptake inhibitors, indirect action. Now we have a drug which does not act as reuptake inhibitor, but the drug comes and causes increased release of stored Na. So we have the second drug which causes increased release of stored Na. So suppose in this vesicle 10 molecules of Na are there. 10 molecules. Normally one is released at a time. Only one molecule is released. You give a drug, it comes to the vesicle and says, why only one? Release 5. So more Na will come into the which place? Synapse, and more stimulation of. So again, which substance is acted on receptor? The drug or Na? Na. What has the drug done? Increased release of stored Na, or you can say another word of saying the same thing, displacement of Na. Displacement of Na from the vesicle. Again, indirect action. Indirect action again. The first drug here acting by this mechanism is tyramine. Tyramine is a food dietary amine. It is present in food like cheese, wine, beer, certain kind of meat, basically any fermented product, packaged food, pickles, any fermented product, tyramine is there. What is tyramine? It's an amine. How does it do? How does it act? By causing release of Na. That is what it is doing. So if you eat cheese, cheese contains what? Tyramine. So it can cause increased release of Na. An increased release of Na can stimulate which receptor? Alpha 1. More alpha 1 stimulation. So vaso. And therefore what can go up? So this is called what? This is called what? Cheese reaction. What is cheese reaction? Increase in BP on eating what? Tyramine containing food. The common example being cheese. Do you eat cheese? Do you eat cheese? Yes. Do you think your BP goes up every time you order from Domino's? No. Why? Why? You're eating. That means which route? In our GIT, I'll draw a simple diagram. This is your GIT. In your GIT, there is an enzyme called monoamine oxidase. MAO enzyme. Full form is monoamine oxidase. So this enzyme oxidizes what? Amines. So whatever amine is present in your food is oxidized, broken. So tyramine, which is present in cheese, is broken by which enzyme? Which enzyme? MAO. So you eat cheese, cheese has tyramine, but tyramine in cheese is broken by which enzyme? MAO. So nothing happens. You can eat cheese. So cheese reaction will happen in which individual? Who are taking which drugs? MAO inhibitors. MAO inhibitors will be discussed in depression, not here. Tyramine. Okay. Second drugs which act by this mechanism are called amphetamines. Very, very important. This is the drug which is important. Amphetamines. Very, very, very important drugs. Amphetamines. They are also indirectly acting, as I have told you, increased Na release. Their highly amphetamines are highly lipid soluble drugs. So highly lipid soluble, they will cross which barrier? Now you combine all the 2 points. Amphetamines are highly lipid soluble drug. If you take a tablet of amphetamines, all of it will cross blood-brain barrier and move where? In CNS. What the drug does? It goes to vesicle and says release what? So now ultimate effect is that when you take amphetamines, it will have increased Na in CNS. That is the action. There will be more noradrenaline released in CNS. Now what will be the result of such an drug? When Na increases in CNS, what is happening? Tell me. When Na increases in CNS, do you feel sleepy or active? So sedation, sleep decreases. That is the first action. When do you want to decrease sleep? In which disease? In disease that we call as narcolepsy. Narcolepsy has excessive daytime sedation. So first use of amphetamines is in treatment of narcolepsy. Narcolepsy, Na increases, sedation goes away, sleep goes away, you can treat narcolepsy. Second action, when Na increases in your brain, it increases your attention span. Your mind becomes more active. Fatigue goes away, your mind becomes more active, increase in attention span. Where can this property be used? In treatment of ADHD. Second use of amphetamines. Third, when Na increases, your mind is active, it decreases appetite. So where can this property be used? Decrease in appetite. Treatment of obesity. So in theory, amphetamines can be used in treatment of these 3 conditions: narcolepsy, ADHD, obesity. They are because of sleep deprivation, sleep reduction, appetite reduction, and increase in attention span. The same things, the same action, you can write as side effects. Same action. What is happening to sleep? What is happening to sleep? Decreasing. So how will we write as side effect? Insomnia. Too much insomnia or CNS activation? Seizure. What is happening to appetite? Hepatitis. So how will write as side effect? Weight loss. In a child with ADHD is a disorder of childhood. Patient is a normally school going age child. You have given him amphetamine. Amphetamine treat ADHD, but his appetite decreases, so weight and growth. What will happen to growth of the child? If child is not gaining weight, obviously he'll get growth retardation. Do you want that? Why? Who is an ADHD patient? Have you ever wondered what is the classical sign of an ADHD child? The child school teacher is the first to complain. During PTM, he tells the mother or the father that your child is very inattentive. He disturbs the whole class, does not listen to me. Try to tell him something. He just, does not focus on thing, disturbs his. One day he's, disturbing this fellow. Another day he's doing that. We cannot keep him in the school. He disturbs the decorum of the class. All the teachers have complained against him. So along with the result, here is the TC of the child. Take him somewhere else. So this is the story of that child who has a disease. His attention span is low. His mind deviates. He fluctuates. He is naughty in terms of the normal layman, and therefore he has to change the schools frequently. He goes to somebody's home. His parents take him to their friends, family members' home. The child is naughty. His attention span is low. He jumps from one chair to another. Sometime he's caught. At one point he's playing with the television, then he gets bored, throws and goes there playing with the computer, tick tick tick, gets bored. Sometime he's downstairs, sometime he's upstairs, breaks this, that, sometime he's in kitchen. Friends say, we do not bring him. He's broken this toy, that toy. No. Stay away from this child. They tell their children. So for that child and that parent, it's still their child. They cannot take him anywhere. They are fed up with that child. He commits all these things in house also. He cries, he shouts, they beat him up, they are fed up, but still it is their child. You just not throw it like you throw the mobile. So you give him amphetamine. Amphetamines increase Na in your brain. When Na increases, your attention span increases. So now the child can focus, he can listen, he is improving. But his appetite is going down. He's lost a lot of weight. Earlier, let's say he was 25 kg, now it is 18 kg. He's become very thin. Growth retardation. So these are the problems. Final, in amphetamines, they are sympathetic drug. So what do you think will happen to BP and heart rate? Too much of this, arrhythmia. Fourth side effect, just imagine, there is a drug that you take and your mind becomes very attentive. Attention span is increasing. You read, you remember. You read, you remember. Attention, mind is able to focus. Your sleep is going away and appetite also going away. So you take this wonder drug 1 week before exam and you are able to study for 20 hours, still remember without sleep, without food. So are you likely to give up this drug or use it again? If you are the student taking amphetamine before exam, will you take it again or give it up? We all know the answer. Second, you are a young, wealthy individual. Your father is a great doctor. He is very busy, but he has millions of rupees, and you are the only child who has the responsibility to spend that money that your father and his mother both have earned. So you started drinking at 10 years of age. Okay? Because you wanted to enjoy. There's so much money. Your father is also a drunk, and wherever he goes, alcohol. You started drinking 6th, 7th standard. By the time you reached college, you are tired of alcohol because if you drink alcohol too much, you feel sleepy. You start drinking at 10 p.m. By 1 p.m. or 1 a.m. or 2 p.m. over 2 a.m. you are sleepy. But then you want to party all night. You want party to begin at 10, 11, 12 and continue till morning. You want a drug that will make your mind so active that you can see music. You cannot hear, but you can see the beats. Your mind is so active that it can feel emotions. It can have a direct conversation with the God. And you should not feel like hungry or something of that sort, so that you can enjoy the party. So which kind of party we are talking? What is this party called as? So you need a drug that classically fits the description of amphetamines. So amphetamines have what we can call as habit forming or abuse liability. They can be used as performance improving drugs by students, or they can be taken as recreational drugs in rave parties. So these are the drug amphetamine form used in rave party is called crystal meth. That's a type of amphetamine. Layman term is crystal meth or crystal. So amphetamines have several problems, particularly the abuse liability. Once you start, the patient does not want to give up. Now come back to these, because amphetamines have so many problems, they are not drug of choice anywhere. So if you are asked drug of choice for narcolepsy, the drug is called modafinil. If you are asked drug of choice for ADHD, you are looking for a drug called methylphenidate. There is no drug of choice for obesity, but there are three drugs that you have to remember. They are liraglutide, which is nowadays an anti-diabetic drug causing weight loss. Very important, we'll discuss in diabetes. Liraglutide. There is a drug called bupropion. Bupropion is an anti-depression which causes weight loss. Anti-depression bupropion. And there is a drug called topiramate. Topiramate is an anti-epileptic drug. Anti-epileptic, anti-seizure drug that causes weight loss. So these are three drugs which are used today in treatment of obesity. Liraglutide, anti-diabetic, we'll discuss in diabetes chapter. Bupropion, antidepressant, we'll discuss the drug in treatment of depression. And topiramate, anti-epileptic drug, we'll discuss in the epilepsy chapter. All three drugs cause weight loss. There is no drug of choice for obesity. So these are three drugs which are commonly used nowadays. All cause weight loss. So amphetamines, important topic. Amphetamines, centrally acting, increase and release, actions, possible uses, side effects. Coming to details of narcolepsy. I told you will come to details of narcolepsy. In narcolepsy, actually there are 4 symptoms, but 2 are important which we'll discuss. The main symptom in narcolepsy, main symptom is excessive daytime sleep. That is the main symptom in narcolepsy. Patient feels sleepy throughout the day. Sleep attacks are there. Sleep attack. Like when you open the book, you get a sleep attack. Immediate. But the moment you close the book, that goes away. Here the patient has irresistible desire to sleep. So for treatment of this, we give several drugs. The drug of choice, as I've told you, is which drug? Modafinil. How does it act? Modafinil is a reuptake inhibitor of Na. So that is drug number 1. Drug number 2, amphetamines can be given. There is an amphetamine related drug which is called solariamfetol. It is also an amphetamine, but name is slightly different. And third is very, very important. So amphetamines can be used. They are not drug of choice, but they can be used. They also decrease sleep. Solariamfetol is a type of amphetamine. Third is a drug very, very important, that is called pitolisant. Now try to understand this drug. This question was recently asked. So try to understand. This is slightly off the topic, but let's try and understand. You see, histamine keeps you awake. Histamine increases wakefulness. That is why when you take antihistaminic cetirizine, you feel sleepy. Histamine keeps you awake. H3 receptors are there. H3 receptor, if you remember, I told you, is an autoreceptor in histamine. Autoreceptor. H3, histamine type 3. What do autoreceptors do? They decrease the neurotransmitter release. So they decrease histamine release. If histamine is low, what will you have? Sleep more or sleep less? This slightly complex, to try to understand. Histamine keeps you awake. Histamine means awaking. H3, histamine type 3 receptor is an autoreceptor, presynaptic receptor. You remember alpha 2? Same histamine, H3. What is alpha 2 doing? Decreasing the release of Na. The H3 receptor is decreasing the release of its neurotransmitter, which is histamine. So if histamine release goes down, you will have sedation or activeness. Sedation. So if we develop an inverse agonist on H3 receptor, then what will be the action? What is the H3 receptor doing? H3 receptor is decreasing histamine release. So inverse agonist of H3 will take the reaction which direction? Opposite. So it will cause what? Increased histamine release will cause what? Less sedation, more sedation. And that is what is pitolisant. It is an inverse agonist at H3 receptor. So another example of inverse agonist, one I told you, DMCM or beta carbolin, another is pitolisant. So the first symptom in narcolepsy, is excessive daytime sedation. There are many drugs for treatment of sedation. The best drug is modafinil, but amphetamines are used. The new drug that is used is pitolisant. What is pitolisant? Inverse agonist at which receptor? H3. That is what you have to remember. If you remember every other mechanism, very good. If you do not, nobody is going to ask. That is the only one symptom that we have discussed in narcolepsy. Narcolepsy has 3 other symptoms, but the second one we need to discuss, that is called cataplexy. Cataplexy is sudden loss of muscle tone. So patient suddenly loses muscle tone, falls down. That is called cataplexy. So another symptom in narcolepsy is cataplexy. Now cataplexy is a different symptom, sedation is a different symptom. Okay. If you are asked drug of choice for narcolepsy, we assume the main symptom, that is sleep. So what is the drug of choice? Modafinil. But if specifically you are asked treatment of choice for cataplexy in narcolepsy, then all the other drugs will not work. For cataplexy, we have to give a CNS depressant, and that is oxybate salt. Oxybate salts of sodium or potassium are given. So sodium oxybate, potassium oxybate, they are the drug of choice for cataplexy. We need a CNS depressant, and that is the oxybate. Sodium oxybate, potassium oxybate, or other oxybate salts are the drug which are used for cataplexy in narcolepsy. So again I'll repeat, if you are asked drug of choice for narcolepsy, without any doubt answer is modafinil. But if you are asked very specifically for cataplexy, then other above drugs will not work. Oxybate salt, which is a CNS depressant, have to be given. That is all about indirectly acting drugs. 2 important mechanisms. Let's revise them. Use this diagram. Indirectly acting, 2 important mechanisms. Either you inhibit NET or you cause increased release. Reuptake inhibitors, 4 drugs are written in front of you. Now modafinil should be clear. Narcolepsy we have discussed. Cocaine I have told you in detail. Increased release or displacement, main drug to discuss is amphetamine. Through amphetamine we have discussed narcolepsy also. We have discussed ADHD and obesity. All things are done. Finally we have some topics, some points in narcolepsy, they are also done. What is the last kind of drug left? Direct, indirect and mixed acting. Mixed acting means both direct plus indirect action. There is nothing much here. Only one drug is there, that is called ephedrine. So ephedrine can act directly or indirectly, both ways. It can act directly on the receptor, cause more release of ephedrine. So it can stimulate alpha 1 receptors, that is used as a vasopressor, especially in pregnancy because it is safe in pregnancy. And it can stimulate beta 2 receptor also. Beta 2 receptor can be used in treatment of asthma as a bronchodilator. These are the two uses of ephedrine. That's all about mixed acting, nothing much. No question is ever asked on ephedrine. Only vasopressor in pregnancy, this point sometimes may be asked. Safe in pregnancy, does not affect placenta or fetus. So if a pregnant woman develops hypotension, ephedrine is a good drug. So we have completed all adrenergic drugs. Okay, we'll take the break and then we come back from the break. We'll start with anti-adrenergic. Okay, the class somewhere 8:15 will wrap up. That is going to be the schedule throughout the 3 days and then 2 days later on. And this is how you will be able to complete most of the pharmacology. Even with such long classes, continuously studying, you will not be able to cover 100% pharmacology. So it's a very long subject. The problem is sometimes they ask very basic question on adrenaline. So you have to start from the very basic. And sometimes they ask the most recent drug which came into market in last 2-3 years. So from here, from 1960 to 2023, everything is asked. So we have to take a lot of time, and drugs are complex and it takes time to read them. So I'm aware that all of you are feeling a bit tired, but that is how the only possible. So now we are going to start with anti-adrenergic drugs. Anti-adrenergic drugs, pretty simple classification. Two types. Either you block alpha receptor, alpha blockers, or you block beta receptor, beta blockers. Two types of drugs are there, alpha blockers and beta blockers, anti-adrenergic drugs. So if you further go into classification, then classification is very simple. Alpha blockers. Let's start with alpha blockers. How many types of alpha receptor do we know? How many types of alpha receptors are there? Two types. So we can have a drug that is going to block both of them. Non-selective alpha blockers, drug type number 1. Or we can have selective alpha 1 blockers, drug number 2. Or we can have selective alpha 2 blockers, drug number 3. Three kind of drugs are possible. Let's focus on alpha blockers first. Beta blocker will come later. So clear? Non-selective alpha blockers block both alpha 1, alpha 2. Selective alpha 1 blocker, selective alpha 2 blocker. Selective alpha 2 blocker is just an experimental drug called yohimbine. So that is just an experimental drug, not available, no use, nothing else is needed. So that is only theoretical. Alpha 2 blocker drug is a drug called yohimbine. It's not used, so we will not discuss in any detail. That is done. So then what is left? How many types of alpha blockers are left? Two types, non-selective blockers or alpha 1 blockers. Alpha 2 blocker is just a name. Okay, it has no use, not available in market, nothing else. So can you tell me now the actions of alpha blocker? Classification we have done. Actions of alpha blocker. Two types are left, this one and this one. Alpha 2 is gone. So actions are mainly due to blockade of alpha 1. So alpha 1, if you block, what will be the main actions? Tell me. Vasodilation. Due to vasodilation, what will be the use of the drug? If vessels dilate, what will fall? BP. So what will be the use of all alpha blockers? Anti hypertensive. All of them are antihypertensive. And if vessel dilate, what will be the side effect? The same property can lead to side effect. What is that side effect? Postural hypotension. So when you will stand up, if you are taking alpha blocker, your veins will remain dilated, blood will pool in lower extremity, postural hypotension, hypotension on standing. What will happen to diastolic BP? Then vessel dilate, diastolic BP will fall. And if diastolic BP will fall, what will happen to heart rate? We did discuss this. Diastolic BP is falling, so heart rate will, so reflex tachycardia. So that is actions of alpha blocker, vasodilation, which has use, side effect. What else is the action of alpha blocker? Where else is alpha blocker present? Alpha 1 present. What was the location of alpha 1? Remember alpha 1? Mnemonic I told you. Probe. So what was pro? So what will happen to prostate? Prostate will relax. That is the second action. Relaxation of prostate, where it will be used? In which disease you want to relax prostate? BPH. And what will be the side effect? When prostate will relax, which process will not occur? So there will be retrograde ejaculation, or ejaculation back into bladder, or you can say sexual side effect. So number 1 side effect, number 2 side effect, number 3 side effect. Number 1 use, number 2 use. That is the broad thing about alpha blockers. So all alpha blockers are vasodilators. All of them are used as antihypertensive. All of them cause postural hypertension. They can also relax prostate. You be used in BPH. We come to the drugs. The non-selective kind of alpha blockers. To first, non-selective alpha blockers. There are 2 drugs. First is called phenoxybenzamine. And the second one is called phentolamine. 2 non-selective alpha blockers are there, phenoxybenzamine and phentolamine. Which is the longer name of the 2? From these 2, which is the longer name? The longer name is longer acting. Simple. The shorter name is short acting, and short acting drug are always quick acting. Short but quick acting, long but slow acting. Simple to remember. The longer acting drug, you can remember, will be a reversible blocker or irreversible blocker. You have a drug which is strong acting versus which is short acting. So tell me just which one will be an irreversible blocker out of the 2. So phenoxybenzamine is an irreversible alpha blocker. And phentolamine is a reversible alpha blocker. That is the question which is asked. Third point, both are used as antihypertensive. That is their main use. As I have already told you, all alpha blockers are antihypertensive. In which hypertensive situation they are used? They are used in pheochromocytoma. So pheochromocytoma is hypertension. Some points about pheochromocytoma. It's a tumor of what? Adrenal medulla. It produces and secretes which substance into blood? secretes noradrenaline or adrenaline, both of them. 80% tumors secrete what? Norad, and 20% secrete adrenaline. So most of the tumors are Na secreting tumors. Most of pheochromocytoma are noradrenaline secreting tumors, 80% tumors. What is the symptom? Patient has hypertension. Along with that, patient has palpitation. Patient has sweating. Patient has headache. So patient mostly comes to you with one of these complaints: sweating, headache, palpitation. And when you investigate, his BP is found to be high. You further investigate, you find a tumor in lateral medulla. That is a case of pheochromocytoma. So you tell me, pheochromocytoma is a tumor. Broad things I have told you. What will be the treatment? What is treatment of any tumor? What is the best treatment of any tumor? Surgery. If possible, if tumor is localized, remove the tumor. Understood? But patient is having hypertension. Patient BP is high. If you start operating in a patient with high BP, then there is a risk of intraoperative hemorrhage. So before doing surgery, prior to surgery, you want to control BP. So control blood pressure before surgery. So which drug will be given? Oral phenoxybenzamine. It will be given prior to surgery, a week or two prior to surgery, to control BP. That is the use of phenoxybenzamine in pheochromocytoma. Before surgery, 1 week before surgery, you will put the patient on phenoxybenzamine. Alpha blocker dilates vessels, brings BP under control. So use of phenoxybenzamine, is it that clear? Point number 4. When is the drug given? Drug is given before surgery to control what? BP. What is the route? Orally. Come to phentolamine. Phentolamine is quick acting, so it is given IV. IV phentolamine use. Rapid acting drug, I have told you, given IV for hypertensive crisis in pheochromocytoma. PCM I am using as the short form for pheochromocytoma. So if a patient of pheochromocytoma develops very high BP, hypertensive crisis, then which is the drug to be for immediate action? Phentolamine. Similarly, we discussed clonidine withdrawal. What was happening on sudden clonidine withdrawal? Rebound hypertension. Which drug? IV phentolamine. And we also discussed a reaction on eating cheese that was happening, called as cheese reaction. So in cheese reaction, what was happening? Hypertensive crisis. Which drug? IV phentolamine. So phenoxybenzamine is oral, long acting. Phentolamine is IV, quick acting. So if you want long action, slow action, phenoxybenzamine. If you want quick action, IV route, phentolamine. Both are alpha blockers, vasodilator, same action, only route is different. Okay. So this is what you are asked. Before surgery, if you want to control BP, which drug is given? Oral phenoxybenzamine. These are alpha blockers, non-selective. Understood? So far. Now come to pheochromocytoma in detail. We are looking for adrenaline secreting pheochromocytoma. The 20% type pheochromocytoma which are secreting what? Adrenaline. Forget noradrenaline secreting. Adrenaline, as I have told you, can act on alpha 1 and also on beta 2. Norad does not act on which receptor? Norad does not act on beta 2, but adrenaline can. For alpha 1, high dose is needed, alpha 1 action, and for beta 2, even low dose is sufficient. So alpha 1 action comes at high dose and beta 2 action of adrenaline comes at low dose. Suppose example we are taking that for high dose means 20 molecules and low dose suppose means 10 molecules. This is an example. Okay. Imagine that this is the tumor. It is secreting what? Adrenaline into blood. How many molecules? Let's take an example. It is secreting 30 molecules. So from the tumor, what is released? Adrenaline secreting pheochromocytoma. So adrenaline is released. How many molecules are released? 30. So at 30, which action will come? Alpha 1 or beta 2? It is low dose or high dose? So this adrenaline which has been released will go and act on the alpha 1 receptor and cause what? Vaso. So suppose if this was the BP, this was the level of BP. Here we have given adrenaline high dose. Adrenaline will act on alpha 1, BP will rise. This is the alpha 1 action. Clear? We have given adrenaline in high dose. It will act on alpha 1, BP will increase. That I have shown BP increase. Then body after some time will metabolize adrenaline. There comes a situation where only 19 adrenaline are left in blood. The rest are metabolized. How many are left now? Less than 20. Only 19 are left. Rest are metabolized, excreted. Concentration has fallen. But 19 concentration, which action will come? For alpha 1 action, how many molecules are needed? 20. How much is the concentration in blood now? So it is less than 20. So which action will not come? But at low dose, low concentration, which action can come? So now this adrenaline will go and act on beta 2, producing what? Vaso. So BP will slightly fall. This fall is due to beta action. Further metabolism of adrenaline will continue. And after some time only 9 are left. But 9 concentration, which action will come? How many are needed for beta action? 10. 9 is less than 10. So now no action will come and BP will come back to baseline. So when you give adrenaline, look at the graph. When you give adrenaline, initially BP, what happens to BP initially? Goes up, because when you have given concentration is high, alpha 1 action. After some time, concentration falls. So B alpha action will go away, beta 2 action will come. This is called biphasic response. Biphasic response on BP. So adrenaline has a biphasic response on BP. Initially it causes rise, alpha 1 action, then it causes falls, beta 2 action, then comes to normal. Are you following me or lost? This was the patient who came to you today. What is the date today? 24th. 4th or 3rd of June. You are the doctor, surgeon. You made a diagnosis that you are suffering from pheochromocytoma. Okay. What is the definitive treatment? Surgery. But before surgery, what has to be brought under control? So you have started this patient today on alpha blocker. Which alpha blocker you have started today? Which is the alpha blocker given preoperatively? Phenoxybenzamine. So you start the patient on phenoxybenzamine. From the tumor, again what will be released? Adrenaline. So after some time, let's say you again give adrenaline. How many molecules again? Same cycle. 30. Trying to act on which receptor? But alpha is blocked because you have given which drug? Alpha is blocked now. So all the 30 can act only on. By alpha is blocked, so they will go to which receptor? So excessive beta response will come. Patient will develop severe fall in BP, and this is called as vasomotor. Vasomotor reversal of Dale. Dale was the scientist who discovered this phenomena, so he named it after himself. What is this vasomotor reversal of Dale? Vasomotor reversal of Dale says that if adrenaline is given after an alpha blocker. So try to understand, if adrenaline is given after an alpha blocker, then instead of biphasic, it produces only fall in BP. That is vasomotor reversal. So normally if you give adrenaline, look at this diagram. Normally if you give adrenaline, what happens to BP first? Rises, then falls, biphasic. But if you give alpha blocker first, then you give adrenaline, then it can act only on which receptor? Beta. So excessive beta response, excessive vasodilation, only fall. So vasomotor reversal. Dale discovered it. It is seen clinically significant. Where do you see it? You see it only in adrenaline secreting pheochromocytoma. So if the patient is having adrenaline secreting pheochromocytoma and you give only phenoxybenzamine, alpha blocker, patient will go into vasomotor reversal. So in adrenaline secreting pheochromocytoma, preoperatively, what is done? You give an alpha blocker, and after alpha blocker, you also add a beta blocker. So you give phenoxybenzamine, then you give propranolol. You block alpha, you block beta also. So preoperatively, beta blockers are also used in pheochromocytoma to prevent which phenomena? Vasomotor reversal. Clinically, how this question is asked? Question I'll tell you. 40-year-old female with history of pheochromocytoma. It is given that the question patient is a known case of pheochromocytoma. Presented to emergency. Came to emergency with severe rise in BP. BP was 220 by 120. Along with severe headache. So this is how the patient presented. She gave a history of pheochromocytoma. She came to emergency. In emergency, BP was found to be very high. She was having severe headache, palpitations, sweating, other things. The junior resident, the attending doctor, you can say, in emergency, who are present? Senior consultant or junior resident? Who takes care of the emergency? The junior doctors. So JR, non-acad JR mostly, or doctor whosoever was attending, took pheochromocytoma. Which drug is given to control BP in pheochromocytoma? Alpha blocker. So he gave, in emergency, he will think of which alpha blocker? So he gave IV phentolamine, which is an alpha blocker. 30 minutes later, Patient went into shock with BP of 40/10. What has happened here? What has happened? Patient has gone into what? Vasomotor, and this is possible only if the patient had a case of adrenal secreting. It cannot be a case of noradrenaline secreting because NA does not act on beta 2. So NA cannot cause fall in BP. So this is how this question is given to you. This is how the importance, clinical significance of vasomotor reversal. So you can write this. This is vasomotor reversal of Dale. And this is the diagram. This is the graph which is given. That patient is given adrenaline, initially biphasic, then patient is given adrenaline, fall in BP. What is this drug? So either they ask the drug or they ask the phenomena. What is the phenomena? The phenomena is asked, it is vasomotor reversal. If the drug is asked, it is the alpha blocker. So that is what is about pheochromocytoma pharmacology. This much if you know, you will be able to solve every question. So alpha blockers, non-selective. How many types of non-selective? This is the non-selective alpha blocker. How many types? 2. Phenoxybenzamin, pentolamine. Which is the main disease that you have to think about? Orally, long action, phenoxybenzamin. IV, short action. Be careful in which pheochromocytoma, because what can happen? Vasomotor. What is vasomotor reversal? After giving adrenal, only fall in BP, because you have given alpha blocker first. We come to selective alpha 1 blockers. Selective alpha blockers will end with zosyn. So we have prazosin, terazosin, doxazosin. These are the main drugs. Doxazosin is the longest acting of the three. Longest acting out of the three is doxazosin, and therefore can be given once in a day. So that is a one-liner question. D for daily. So doxazosin is given daily, once in a day. These are the drugs. Zosin. Every zosin is a selective alpha 1 blocker. Their use remains the same. Number one use, they are used for treatment of hypertension. These drugs are never first line hypertensive, they are second line anti-hypertensive drugs. They are not the drug to start hypertension treatment. They are not the best drug for hypertension treatment. They are second line drugs. Once first line drugs fail, you can add them. They have an advantage. What is that advantage? These drugs have a favorable effect on the lipid profile. Favorable effect on lipids. What do you think is the favorable effect on lipids? Which kind of lipid should increase? HDL. And which kind of lipid should decrease? LDL and triglycerides. So that is their important point. So if patient has deranged lipids with hypertension, they are good drugs. But normally they are second line antihypertensive. They are not drug of choice anyway. This use is never asked. The second use is what makes them useful or more interesting. They are used in BPH. Very, very important disease, BPH. Try to understand BPH. So let's take this example or diagram. This is the bladder formed by the detrusor muscle. The bladder is filled with urine. The normal prostate is this. This is the normal prostate. With age, prostate grows. This is a physiological problem. So in elderly male, prostate has overgrown. This extra muscle is now there in prostate. Red, prostate has overgrown. So now this extra prostate, what will it do? It will compress the urethra, because now there is more muscle. So urethra will become compressed. Instead of this, it will become like this. So passage of urine will easy or difficult? So patient has number one symptom as difficulty urination. So his bladder is filled with urine, but he cannot pass it. So difficulty urination, which leads to increased frequency of urination. He has to go again and again for urination. Happening in elderly male, this is the case of BPH. There are two main symptoms, difficulty and frequency. Patient is unable to pass urine, and because the bladder is filled, he has to again and again go for urination, frequency of urination. You want to treat. So first thing is, forget the prostate, look for symptom relief. Patient wants very quick or rapid symptom relief. Just imagine the pain that will happen once your bladder is completely filled with urine and you are unable to pass urine. The patient has intense pain, bladder is stretching. Okay, what do you want to do? You want this urine to pass. So what you have to relax? Which muscle you have to relax? Prostate. So which drugs will come useful? Alpha 1 blockers. So that is Zosyn. The Zosyn drugs you will give, they will immediately relax prostatic muscle, urine will come out. So alpha 1 blockers provide which relief? Symptomatic relief. Will they reduce the size of the prostate? No. So once you have given the symptom relief, then you can look for the reduction in prostate size. For that, we give drugs which are 5-alpha reductase inhibitor. Later on in endocrinology, we will discuss about these drugs. 5-alpha reductase enzyme inhibitor. Drugs are like finasteride. 5-alpha reductase inhibitor. They will reduce the size of the prostate. Do you think size will reduce in hours or days? So this will be very slow action. It will take many months, 3 to 6 months it will take. So these are drugs used in treatment of BPH. One is for symptom relief, one is for long-term relief. Both the drugs are used in combination. So use of alpha blockers is in treatment of hypertension and in treatment of BPH. In treatment of hypertension, they are first line or second line. So now if you combine use number 1 and 2 and you are asked patient has hypertension with BPH, tell me the best antihypertensive. Now what will you say? What is the best antihypertensive for this patient who also has BPH? Now alpha blockers, alpha 1 blockers to be more precise, become the drug of choice. So in hypertension, this kind of question is asked. That patient has hypertension, along with hypertension he has this also, which drug will you select? We will come to that in hypertension. The uses are clear. Alpha 1 blocker Zosyn. Okay, everyone? Come to the same thing, you can write a side effect. What was the side effect of alpha blockers? Postural hypotension. The side effect, tolerance develops after few days. Like tolerance develops to effect, tolerance also develops to side effects. So this postural hypertension will be seen initially when you start the dosing. So what kind of hypertension or effect this is called? First dose hypotension. Maximum seen with prazosin. So the problem with alpha blocker is hypotension. This hypotension is initially, for initial few weeks, patient will have hypotension. Later on, patient will develop tolerance. So it is called first dose hypotension. Maximum with prazosin. So this hypotension creates a problem. When we use alpha blockers for BPH, which side effect comes up? Hypotension. So further research was done in alpha 1 receptor. It was discussed or discovered that alpha 1 is also of two types. Alpha 1A and alpha 1B. Alpha is of two type, alpha 1 and alpha 2. Alpha 1 is also of two type, alpha 1A and alpha 1B. B can simply help you remember blood vessel. So it is the alpha 1B type which is present on blood vessel. Alpha 1A type is present on prostate. This discovery was made. So which is the alpha 1 present on prostate? Alpha 1 subtype A. So after this discovery was made, we developed a selective alpha 1A blocker. Selective alpha 1A blocker. The drug was called tamsulosin. 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 What will be the use of tamsulosin in which disease? You will use it for BPH. And what will be the advantage of tamsulosin over zosine? It will cause very little, minimal hypotension. Because it is not blocking alpha 1B. Third point, if somebody asks you, bhai, is there any side effect that it can also cause? So there are many, but you remember floppy iris syndrome. It can affect the tone of the iris, probably in patients undergoing cataract surgery. Then impairment or retrograde ejaculation. These problems are more, hypotension is less. Use is BPH. So tamsulosin is alpha 1A blocker. This drug will not affect which organ? Blood vessel. So which problem it will not cause? That is the main thing. Which organ it will affect? Prostate. So where it can be used? BPH. Again I will ask you, please remember, if you are asked now hypertension with BPH, drug of choice. First option is given doxazosine, second option is given tamsulosin. Now which one will be a better drug? Alpha 1 blocker. You are given two options. One is doxazosine, zosine drug, one is tamsulosin. What will be your choice now? How many of you say doxazosine? Raise your hands. Majority. Lot of you. And how many of you say tamsulosin? In a patient of hypertension with BPH, which is the best drug? Tamsulosin, doxorubicin. How many said tamsulosin? Anyone? The answer is correct. It will be Zosyn, because tamsulosin is not an antihypertensive drug. So please remember, Zosyn, as I've told you in beginning, are antihypertensive and for BPH. They can be used for both. But tamsulosin is selective for prostate. It is used only for BPH. It has no role in hypertension. So these are alpha blockers. So summary, tell me non-selective alpha blockers. What are the names that come to your mind? Phenoxybenzamin, phentolamine. And which disease mainly we have to discuss? Pheochromocytoma that we discussed. The second type of drug is alpha 1 blocker. The drugs are called Zosyn. And which disease are there? Hypertension and BPH. The third drug is alpha 1 A blocker. The drug is called tamsulosin. And which disease? Only BPH. The fourth drug that we discussed was alpha 2 blocker. It was only a name, no use so far. That was Yohimbe. Then there are, to complete the topic, some miscellaneous alpha blockers. Miscellaneous names which block alpha. So indoramin and urapidil. These are also alpha blockers and they are also used as antihypertensive. We are done with which class of drugs? Alpha blockers. Just write as one liner MCQ. Prazosin. Prazosin also used in two diseases which are asked quite commonly: scorpion sting and also in frostbite. Both the disease have vasoconstriction. Prazosin is an alpha blocker vasodilator, so used there also. Scorpion sting, frostbite, prazosin, vasodilator we use. One liner question, nothing. So any problem with alpha blockers? Very simple. Remember the classification, remember the use, everything is clear. I think that's the time we have for today's discussion. We've already crossed 8. If you people said, I'll tell you beta blocker also, but I don't anticipate that you will be in the mood to sit any longer. So it was day 1. So we'll not stretch the session beyond 8. That is the time we discussed. Tomorrow, see, we are still short on the target. We wanted to complete beta blocker also and cholinergic drugs also. So another 1.5 hours we are short. We'll try to make up tomorrow. But anyhow, we'll start tomorrow 8 AM. And if anybody has any problem in what we have discussed, please feel free to come. And you can also, for query after I'm gone, you can join the Telegram group, that is Pharma Guru. Dr. Arpit Agarwal. This is the Telegram group. You can join. And if there are any queries after I'm gone, anytime or anything you want to ask, you can put that query on that Telegram. Okay, so that's all we have for today. I'll see you tomorrow 8 AM and we'll continue and we'll discuss some more important topics tomorrow.